everybody. This session is all about the homelessness and its impact on our patients in the emergency department. I'd like to introduce our first speaker, Ben Del Bueno. Take it away, Ben.
So, like I said, this is prioritizing homelessness in emergency medicine education. So I'd just like to first start by introducing our speakers today. So we have Alexis Kimmel, resident physician from Cincinnati. I'm Ben Del Bono. I'm an intern at VCU. We have Hassan Salhi, associate professor at Emory. Joel Mall, residency program director and associate professor at VCU. We have Kelly Jarrell, clinical instructor at Cincinnati. Melissa White, program director and associate professor at Emory. We have Rohit Manaktala, assistant professor at University of Texas Southwestern, who unfortunately can't be here today. And we have Sally Santon, senior associate dean at VCU. All right, so today we will start by sharing a relevant clinical case, some background on this topic, and then we will share preliminary results from EM residency program survey. There will then be a Q&A session where we will discuss 4 topics that we think are worthy of including as curriculum content. At any time throughout the didactic, please feel free to include any questions or any thoughts that you have in the chat box. And we will get to those. We'll have plenty of time to get to them at the end, or we can do so during the Q&A. So to start with a clinical case. So a man in his early 40s with a history of insulin-dependent diabetes and bipolar disorder presented to the ED by ambulance from a social services office with extreme fatigue, thirst, polyuria, blurry vision, chills for 2 days. Review systems also revealed depression. On physical exam, he was shivering, had dry mucous membranes, non-tender open wounds on his feet, and vital signs were notable for tachycardia, tachypnea, and hypothermia. His initial workup revealed hyperglycemia, ketonuria, and elevated anion gap metabolic acidosis. Management for DKA was initiated in the ED with IV fluids and insulin. So a little bit more history on this guy. He had been prescribed insulin and mood stabilizer at a free clinic. He had been diagnosed with diabetes and bipolar disorder. Some more social history included that he had been experiencing housing insecurity for the last 7 weeks. At that time, he was sleeping on the street since his 30-day eligibility at the Salvation Army had expired. Prior to this, he had moved to Virginia from out of state to be closer to his 4-year-old son. He was robbed 2 weeks ago and had his belongings stolen, including his proof of citizenship. He had no health insurance, was currently applying for Medicaid. He had none of his diabetes medications. He had no fridge for access for insulin, no glucometer, or no test strips. He had visited this ED twice in the last month with similar symptoms, and he denied any alcohol, tobacco, or drug use. So in the ED, an insulin drip was started, IV fluid bolus was initiated, his anion gap subsequently closed, heart rate decreased in the 80s, and repeat blood glucose measures were in around 150 to 200. He's admitted to the ED observation unit for continued hydration and care for his feet. Social work was consulted and provided him with housing resource information. So managing this man's DKA was the easy part. However, prior to discharge, he expressed multiple additional concerns. So this was during COVID quarantine peak times. Shelters were at half capacity. He was afraid that he was going to be discharged straight back to the streets. He typically slept outside an alley next to a church 3 blocks from the hospital. Since he was robbed at gunpoint 2 weeks ago, he had experienced nightmares and flashbacks. It was also wintertime. Cold weather had made him miserable, worsening his depression and causing him to be suicidal at times. He had no health insurance, no documentation of citizenship. He had no money to afford medications, and even if he could afford insulin, he said he had no access to a fridge. He had no means of checking his blood glucose or eating meals consistently. He also shared that during similar visits at other hospitals, he had been told that he couldn't have been homeless because he dressed too nice, and that he was accused of bringing his situation upon himself. So Dr. White is going to talk just a little bit about the social factors that affected his medical outcomes.
Sure, thank you. So when we start talking about our patients, and before we kind of delve into this case a little bit more and talking about homelessness and the ED and education of our residents, you know, when we are talking about our patients, remember they're people and patients who have homelessness or housing insecurities, and not a homeless person, and kind of that differentiation of remembering that they are people first. And when you put that in the context of social determinants of health and social factors, these four areas that we're displaying before you are just a small kind of summary of some things that we came up with, but clearly not completely expansive of all the social factors and determinants of health with relation to what this gentleman has gone through. So some things to consider in this case with his hyperglycemia DKA, the fact that he was not able to have his insurance or insurance card available, and or could not maintain insurance on his own as well, just given his situation, and the fact that he did not have financial capabilities or money at that time, nor refrigeration for his insulin, which we do see quite often in our patient populations. And so these are all areas that are you have to tease out as quickly as possible, and or know those resources that maybe you can perhaps help your patient with, and or to understand kind of why that patient may perhaps be in the situation that they're in. Again, in dealing with neuropathy and wounds, perhaps he did not have the shoes or has the ability to have transportation in order to maintain self-care. And this is likely the case with a lot of our patients who are in particular homeless and or have housing insecurity, which we'll talk about that in just a minute as well too. And then this risk of hypothermia, depending again on where your patients are and where you live throughout the United States. We actually had a little bit of an issue with tents being put up in our area, which sounded like a really great solution to perhaps the housing situation. But actually what happened is when we had a cold snap, we had a tremendous number of hypothermia, cardiac arrests, because the patients were actually left in their tents. So sometimes even good meaning decisions to try to create a better social determinant of health or to help our patients sometimes may not actually come out as a positive means in the end. And then with regards to his depression and suicidality, again, not so much maybe that it was particularly mismanaged, but perhaps he is not able to get his medications, not able to get to the mobile health unit to obtain those medications. Perhaps he needs to be on something else. And again, this will cause him to come back and or not be able to have that mental capacity in order to continue to have self-care. So considerations from the standpoint of a program director and education, just some things to consider. Are our EM residents, faculty, staff aware of how these social stressors really affect health outcomes for our patients? And that it's not just really one answer for one patient. It's again, all of these different determinants of health and which ones are playing in the most that we can be most effective in. And so this leads into, are our EM residents prepared to effectively care for patients that do have these very complex social needs? And then really, how do we connect them with those resources within our communities? And to that point, do our residents know what those social resources are within their catchment area? The concept of how many, like what does your population look like that in your catchment area who are experiencing housing insecurity? And again, what does that look like? Is it homelessness? Is it that they are living with somebody else and they don't have their own home? So there are kind of many different considerations when you are discussing this with your patients, understanding that even sometimes some of your patients in your mind may be homeless, but in their minds they may not be. And so there's a little bit of a nuance and vice versa as well. Especially when it comes to perhaps living with somebody else in their house or sharing rooms. Further things to consider, do our EM residents understand how the affordability of medications impact our patients, and then their success for discharge plans? And then what practices now will prevent future episodes of this patient's DKA, and how will that be managed in the future to help our patients in the long term as well? And then that falls also in line with the likelihood of them to return to the ED. So all of these are very big considerations when you're caring for our patients.
Thank you, Dr. White. All right, so we will move on with some background now, and Lex will be talking for a couple slides.
Hi, everyone. So I just want to talk about the importance of teaching residents about taking care of patients experiencing housing insecurity. This 2019 data shows that there are over 500,000 individuals in the US who are experiencing housing insecurity. And an estimate just from a couple of years prior showed that there were almost 1 million ED visits by patients who are experiencing housing insecurity. So this is something that we all see often. Some places more than others, but it should be something that is routinely taught in our formal education because of the frequency that we care for these patients. And I just wanted to mention in this talk, we'll be primarily using the term housing insecurity rather than homelessness, but there are some content experts who treat these terms a little bit differently. So I wanted to just briefly touch on what I found. Housing insecurity seems to be a term typically used for more at-risk patients. So those who have difficulty paying rent, those who use more than 50% of their household income on housing, those who have frequent moves, those who are living in overcrowded living conditions, and those who are doubling up housing with relatives. And this is typically considered a risk factor for homelessness. And the definitions that I came across for homelessness were, to quote, housing deprivation in its most severe form, and lacking regular nighttime housing, whether that is a shelter or another place that was not designated for sleeping.
Thanks, Lex. So I'm going to take us through just a little bit of recent literature. So in 2015, the National Academy of Medicine developed a framework to educate healthcare professionals on addressing social determinants of health and support the incorporation of social determinants of health into training curriculum for medical schools and residency training. We've also seen a more formal shift in literature advocating for further integration of social determinants of health into emergency medicine training specifically. In 2019, there was the Inventing Social EM that was published from the 2017 ACEP Consensus Conference. This included a series of articles that covered principles of social EM, established overall goals, addressed screening, education, and advocacy of social determinants of health. More specifically, as far as housing insecurity goes, literature has addressed housing insecurity as an important element within social EM. A systematic review by Dr. Salhi and Dr. White in 2017 and multiple commentary articles, some from the Inventing Social EM Consensus Conference, have mentioned research, education, advocacy, and incorporation into clinical care as essential to advancing these efforts. There are multiple articles out that addressed provider experience. So a little bit more about that. Duran's article in 2014 assessed 2 cohorts of EM residents in New York City. This revealed that residents actually learn unique aspects of caring for patients who are homeless through experience and informal teaching, rather than through a formal curriculum itself. Residents noted little formal curricular time dedicated to homelessness at that time. Multiple surveys have actually measured the attitudes of faculty, residents, and medical students towards this patient population. The health professionals' attitudes towards the homeless inventory survey, it's HPATHY survey, has been used in many studies. Some of these findings include that medical students tended to have more positive attitudes and beliefs about patients experiencing housing insecurity than EM faculty and residents, and that therefore role modeling might have a detrimental influence on the beliefs and behaviors of med students and young physicians. The patient experience is also obviously very important. Through different studies that included interviews and surveys, they've analyzed different viewpoints of patients who are experiencing homelessness, specifically regarding their treatment by healthcare providers. Housing insecurity and low social class were most commonly cited as the perceived basis for discriminatory treatment. Unwelcoming experiences actually negatively influence desire to seek healthcare in the future. In one study, a third of the participants experienced discrimination related to poverty, and all types of discrimination in the setting was associated with frequent ED visits, greater severity of lifetime substance abuse, and mental health problems. So as far as current residency curricula, what's out there now? In 2020, there's a paper that was published in Academic Psychiatry that proposed a residency curriculum on housing insecurity. They included 4 educational goals on ACGME competencies. They also know that only 60% of psychiatry programs provided any formal education related to homelessness. An IM residency program in Canada described their own curriculum. And as far as undergraduate medical education goes, there are multiple publications that describe curricular framework for medical students. There are no publications involving emergency medicine residencies specifically for this topic. There was one article that described a curriculum for an EM clerkship for medical students. So Dr. White's going to talk to us again just about core competencies.
Sure. And for emergency medicine, again, with our colleagues in psychiatry and social work and internal medicine who have set these competencies as well and curriculum, really some very interesting things that they have done and are doing. And so although we may not have a lot of publications in this area right now in emergency medicine, we do expect them, and they're definitely in the pipeline. But ABIM and the ACGME and LCME, all of our national organizations have really taken this upon themselves as well too, to say that these topics, social determinants of health, homelessness, everything that kind of encompasses as much as we can get, should be involved in our curriculum and part of our EM model. So in 2019, the social determinants of health actually became embedded into their core knowledge and skills that really they require of any of our graduates within emergency medicine. And so that actually will become part of our testing as well, and I believe 2022. And so this is something that is definitely been put forth by our organization, our national organization, as well as the ACGME, which has put it, even in the milestones 2, version 2 that are coming up, some core competencies and awareness from the resident standpoint of what we need to maybe learn a little bit more of as far as the social determinants of health of our patients and our populations that we care for. And then again, lending a little bit more to the undergraduate medical education, LCME, the standards have also been set discussing societal problems and cultural competency in healthcare, and disparities have been placed within the curricular content within their organization as well.
Thank you, Dr. White. So quickly, I'm going to share some preliminary results of a survey that was done of different EM programs, all ACGME EM programs out there. So this was an IRB approved survey of ACGME accredited EM programs. The aims were to discover the prevalence of the topic of housing insecurity in EM residency education. So essentially, how many curricula are out there so far, and what do they include? And what do people think we need, and what are the barriers? So far, there's been 53 programs that have responded. 83% formally include some form of housing insecurity in their curriculum. If you have not filled out the study and you would like to, there's a QR code here. However, please don't take the survey if you already have, or if someone within your program leadership has already done so. So what were the most common ways that housing insecurity is addressed in curricula? Collaboration with social work was the most common. This was then followed by lecture format and incorporation into medical cases. Workshops and journal clubs were also utilized by some. What was thought to be the most important ways that we could include housing insecurity in like an ideal curriculum? Collaboration with social work and community organization partnerships received the most selections of very important or extremely important. This was followed by incorporation of the topic into medical lectures and cases. So the average number of hours per year that are currently dedicated to this topic by the participants was 2.5. And then interestingly, the number of hours that participants felt should be dedicated to the topic was over twice as much. I think it was around 5.7 hours. And this discussed barriers to implementing curricula. Limited available time was the top choice or the top issue for most. Other common barriers included limited content expertise by faculty and limited availability by faculty. Around 9% of programs reported they did not have any barriers. So that was our initial background section, and now we're going to be doing a Q&A on curriculum content. So I'll be handing it over to Dr. Santon, who will be moderating this part of the didactic.
Great. And so are there questions from the group, from the participants? I think you need to type them into chat because you were muted. Any questions about the participants, from the participants? All right, so I think we're going to talk to the people who are doing kind of these curriculum content spaces. Who would like to start and kind of tell us about what they're doing specifically at their institution?
Well, actually, we'll start with, how about we start with this question and then maybe we can open up after?
That sounds great.
Okay.
So Bisan, you can read the question, but we can say it anyway. So how have conditions of housing changed since the onset of COVID that you've noticed in Atlanta?
So that is a really, really big question. We probably could have spent the entire didactic just sort of talking about that. Broadly, what I will say is that certainly the national, like what COVID has really done is very much highlighted the association of housing and health, and individual and public health more broadly, and really brought it into the national conversation. I think it's really also sort of highlighted the spectrum of difficulties that people face with housing. So the number that was mentioned earlier, that 560,000 of people who are actually who are either living in shelters or on the street or places not meant for sort of human habitation, like in their cars or abandoned buildings, is really very much the tip of the iceberg of people who are having sort of difficulty with housing. And that has been really highlighted by the attention that people have, brought by like talking about sort of their impending evictions or the eviction moratorium that's been put in place by the CDC and being challenged in court right now. But also sort of like the calls to cancel rent, and people have really had like a large outcry and sort of thinking about what it means, what sort of housing really means in these times of kind of like of public health precarity and economic precarity at the same time. And so there hasn't really been, other than sort of the CDC's eviction moratoria, the efforts to limit housing and to change the conditions of housing have really been the most effective at sort of the local level. I'll highlight just in Atlanta, for example, and I'm a big critic of sort of Atlanta's sort of historical responses to housing, as anybody here who knows me, but I will attest to, but I will say that there has been very much a concerted local effort to put people in non-congregate settings, either in hotels or place them into rapid housing. It's just really ramped up the political will actually to address the difficulties of homelessness in our city. The last thing that I will also leave you with is that, and I think Ben is going to share this later, is that really the local efforts have been very, very effective at actually like both at addressing eviction and putting eviction moratoria in place and leaving people in their homes, have been very effective actually in decreasing COVID-19 infection rates and death rates as well. And so I think it really has brought a lot of political will and attention to housing sort of conditions. Now, that is not to say that people haven't had difficulties or been evicted or lost their homes, but very much the story is unfolding. So that's like a long and complicated answer to that question. But
sounds good. So Joel, how are LGBTQ plus individuals disproportionately affected by the housing insecurity?
So this is a little bit of a difficult question in the sense that they're both populations who are very difficult to study. Identifying who they are, who has housing insecurity, homelessness, frankly, or certainly anybody within the LGBTQ plus community, but specifically youth are just horribly affected from this. About 40%, up to 40% of homeless youth identify as LGBTQ plus, which is quite tragic. Kids are coming out at a younger age, now typically 13, 14 years old. And it's not surprising that the stats will show that the homeless are, quite frankly, a few months older than that. And so a lot of times that has to do with, with some of the lack of acceptance by the parents and lack of, in combination of resources and other things, whether the schools are set up to handle situations like that too. But they're very vulnerable. They're a young age, they're vulnerable, they don't have resources, they may not have the savvy that an adult would have. And statistics show that they are, unfortunately, are preyed upon by some of the elements of being homelessness. I mean, 58% of them have reported sexual assault, which is about twice the heterosexual colleagues. Also, about 44% have been offered basically for money or for food or for drugs to have sex, which is, again, about twice the heterosexual population by comparison. Higher percent of abused alcohol, and 62% of LGBTQ plus homeless youth have contemplated suicide, which is way higher than the 29% of heterosexual homeless youth. So again, there's lots of vulnerabilities associated with this dual identity, and certainly a lot of increased risk for outcomes.
Let me just ask a question from the panel, from the audience. Given that so much of the issue and the complexity of these patients is kind of social determinants of health, should social activism be systematically taught in residencies? Very interesting and provocative question.
Who's interested in answering that?
I can jump in. I don't necessarily think that I think you cannot make somebody an activist if they don't want to be, or if their interests lie elsewhere. You cannot control what somebody is interested in. And certainly there is no shortage of things for people to be passionate about. What I do think is incumbent on us to teach residents, however, is evidence-based practices and backgrounds for why people present to us in the way that they do in the emergency department. So in the same way that we talk about like diabetes control and upstream factors and diet and all of these other things as sort of background to like understanding DKA and thinking about how to work up hyperglycemia, I think we should also be giving similar attention to the processes of like the social factors, be they related to kind of poverty, racism, sexism, other forms of kind of like discrimination that actually both affect people's health and their reasons for coming to the emergency department. And I think that based on that, certainly we should provide people with resources if they want to pursue further activism. But I would definitely say our first focus should be on kind of evidence-based processes and like thinking about like people's experiences as well, more so than just kind of beating people down with activism per se. So I think that turns to, my experience is that tends to turn people off more than it inspires them, rather than kind of presenting them with evidence. So.
Yeah, I would just add that I think we do have an obligation to teach them to be advocates for their patients, which is a little bit different than activism. And being an advocate for your patient, to be an effective advocate and effective in taking care of patients, we have to consider all social determinants of health. I mean, obviously this is just not housing insecurity, but if we're producing residents and not teaching residents to take these things into consideration, then we're failing our patients. And quite frankly, we're failing the resident.
So how does housing inequity perpetuate structural racism?
So that is also a question that we could spend maybe our whole careers answering, but I'll just sort of provide some jumping off points that I have sort of found effective in starting these conversations with our residents. I think first is sort of the understanding of housing as a mechanism of building equity and passing wealth from one generation to another. Buying home ownership is a means of building credit, building equity, and then owning a home that you can then give to another family member is a mechanism of passing wealth. And I think a lot of residents may sort of understand that peripherally from their own lives and seeing that play out, but they may lack the understanding that that isn't accessible to all of our patients because of sort of historical context of housing as a propitiation of structural racism. So the average income of an African American is 60% that of the average white income, whereas the average wealth of African American families is 5% of that of the average white kind of wealth or wealth of a family. And a lot of that is because of home ownership. And I think residents should be familiar with, if not all, at least sort of the concept of housing policy as sort of a way of functionally, if not overtly, segregating racially or racialized groups from whites and sort of building neighborhoods in certain areas that were designated as desirable or undesirable, and should be familiar with concepts like redlining, which is exactly what that is. Another thing that I have found very interesting and impactful is kind of engaging local public health sources of data. So in Hamilton County and Cincinnati, they publish neighborhood level life expectancy, morbidity, mortality, education data, and using that to demonstrate, because a lot of our residents, are from other cities. And so they may hear of, and I think this is true in most places, they may have heard the names of neighborhoods, but not really have an understanding of what that means in terms of who lives there and what the perception of that neighborhood is locally. And so engaging that local data to show residents that this neighborhood they live in has a life expectancy that's 20 years greater than a neighborhood that's less than 5 miles away. And sort of once you sort of provide that context to residents, it can kind of help them understand or at least frame the conversation about what life might be like in those neighborhoods. And then taking that one step further, comparing those kind of current local neighborhood level data to historic redlining maps, you can sort of start to lay that groundwork for the historical context of how local and national housing policy has sort of shaped that and perpetuated that kind of through history to the present.
That's great, thank you. I want to go back to a question. For those of you who have implemented specific curricular elements, has this changed attitudes around patients with housing disabilities, given that there's so many limitations? Often there's a kind of a callousness or an indifference to patients with housing insecurity because we see them frequently and we feel kind of helpless in the process. So what have you done to how do you feel like you address that, the indifference? That's for anybody, so not a softball.
Yeah, I mean, I would just say that, I think paying attention to the whole concept of social determinants of health, it's something that not every place does. And I think by bringing that up in discussions routinely, specifically, then when you get an ED setting, especially as attending, to model that, to say, can they afford this? What are they going to do with their insulin? If you give them, insulin, is that going to be a simple fix of that? Because we're all looking for the simple fix. I think that, helps bring the kind of group think a little bit along the way. And that certainly is not necessarily targeting just to homelessness, but I think some of these perceptions and some of these experiences, it provides an increased awareness, which I think is a good first step.
I think one of the things that we've done historically in our program is when the residents come in, even before right when the intern year starts, we extend the offer to go to one of our local homeless shelters as well as the jail and other local areas where our homeless or housing insecure patients may be. And what has been really interesting is when we open this up to our faculty and or other residents as well, and they choose to, after they've worked within the emergency department, they go back and it's a little bit of even a different context when they go back and they actually are able to see the homeless shelters, and you have much different questions, different concerns than when you initially start. But it's been invaluable for us actually to start even from the very beginning, right when orientation starts, to even just visit and have this conversation of, okay, these are where a lot of our patients may be coming from when they're talking about coming from X, Y, and Z. And this is how some of the issues arise and why we need to be thinking about maybe this patient needs to be admitted and or how do we help them in other ways. So just one of the things that we've done that I think has been successful and allowed the residents and the faculty who are involved to reflect on what is going on in the Atlanta area.
Yeah, and we've done a modified thing in Richmond. I mean, not exactly the same places, but things more specific to our community. And again, that's been something I think has really helped open the eyes up of people.
Good. So what do we know about the effect of housing on health outcomes and health system use?
Hey everybody, my name is Lex Kim. I'm one of the second-year emergency medicine residents at the University of Cincinnati, and I'm going to be talking about the impact of housing insecurity and homelessness on health outcomes and how these patients interact with the health system. So as ED providers, like we've mentioned, we see the impacts of housing insecurity on health outcomes on a daily basis. And we also understand how access to housing can impact a patient's ability to adhere with the treatment plans that we want to enact. So for example, like we talked about in our vignette, a patient who doesn't have access to refrigeration may have a difficult time controlling their insulin-dependent diabetes. And similarly, a patient who is on a diuretic medication may not want to take this medication if they don't have access to a bathroom. So we also know that adults experiencing homelessness are at increased risk of having chronic medical illnesses like hypertension, diabetes, and HIV. And they also have higher rates of having complications from these illnesses. So when you look at the literature, it really reflects how housing and housing insecurity impacts health outcomes. So a 2016 study by Lim et al. Demonstrated that housing insecurity was associated with poor health outcomes among patients living with HIV/AIDS. This was a retrospective cohort study that looked at approximately 1.7 thousand persons living with HIV/AIDS in the New York City area and were experiencing either homelessness or incarceration. And it saw that the group experiencing homelessness or incarceration had lower overall rates of viral suppression when compared with the comparison group. There was also another study by Buchanan et al. From 2011 that showed improved outcomes when giving patients stable housing. So this one was a randomized control trial that took patients living with HIV and experiencing homelessness and randomized them to either usual care or stable housing with intensive case management. And it saw that these patients that received housing had higher rates of survival with intact immunity and overall decreased viral loads. And then regarding the component of ED utilization, there was a 2009 randomized control trial by Didactic et al. That demonstrated that providing housing and case management to patients living with chronic illnesses and experiencing homelessness reduced hospitalizations and ED visits. So I think going forward, the best manner to teach residents this concept would likely be a journal club format in which you can review the literature that shows these tangible improvements in outcomes when you provide stable housing.
Great, thank you. Let's see. So Vicki, did you have a question? Did you want to ask?
Well, I had actually a couple of questions. One was to talk about there would have been in context a little while ago as to what the Navajo Nation did in response to housing and COVID and isolation. That was fairly interesting. What most people don't realize is that a large percentage of the Navajo still do not live in houses. They may live in trailers, mobile homes, or in hogans. And a hogan is quite literally a mud hut, fairly spacious, often with electricity from a solar panel, but without running water or sewage. Often whatever place they live in, they live with 3 generations, a grandparent, pair of parents, and their children. Usually it's her mother. There's prohibitions against a man living with his mother-in-law. Excuse me. Anyway, leaving that aside, they opened up a lot of community facilities simply to be isolation facilities for people who didn't need to be in the hospital but did need to quarantine for up to 2 weeks, and they supplied food. I thought that was a very interesting response, and there will be more about that in my presentation on Friday. The other question that I raised was simply a more rhetorical question about teaching the tools of social activism. Although I'd like to think that I have a fair amount of life experience, I really wouldn't know how to go about being a social activist and advocating for homeless solutions in my neighborhood. And I do think that simply supplying a stable place to live is one of the best things we can do to combat homelessness, but I wouldn't have the tools to go about making a political difference.
Got it. And so in the chat, if anybody has ideas about how do you kind of support, encourage, whatever, social activism in your residents, go ahead and pop that in if you want. I think there was also a question further back about, it was a good one on resources, right? Is that we often have like a list of resources for them. I remember at one place we had this laminated card of where you could eat breakfast, lunch, and dinner, and it was probably outdated, and it was just not particularly useful because people need more than where they can get a free lunch. And so for the panel themselves, or for the participants who are listening, what are things that you've done besides just having like a list of resources or contacting social work or something like that? And there was a good one from Kelly Doran in the list as well. I don't think she can unmute unless Michelle can unmute her. But tell us, what have you done besides just having a list?
I think people can unmute themselves. No?
I was able to unmute, but I think I put the thing in the chat about housing navigators is one promising model that I've seen here in New York. A couple of emergency departments have done that. We've tried in our emergency department and in some others to do direct referrals to homelessness prevention resources for people that might not be homeless yet, but are at risk of homelessness, to some of the local community-based organizations that do homelessness prevention with like very warm handoffs directly to that organization with like a bi-directional information flow of a warm handoff. I agree that the resource lists are quite limited.
Do other people have navigators, like some sort of a housing navigator? Good. Any idea where the funding is coming from?
I think some of the funding was through specific Medicaid waiver projects that we had in New York. But the examples that I know of were emergency departments that had them, but they were actually employees of a community-based organization. So that type of direct relationship. Because one thing that we've learned is that housing is very specialized. It's very complex, especially depending on where you are and how many services they are. So, even a lot of our social workers don't get much training or don't know much about the complexities of the housing and the homelessness environment. So really did kind of require people that come from that world, so to say.
Kelly, do you want to talk about an advocacy elective? I think that's a particularly useful thing for people.
Yeah, I can mention it briefly. So I know it to kind of dovetail off what Dr. Golden said and Dr. Dr. Trotton, not Dr. Vicky, sorry, mentioned though about kind of not knowing what resources are available. Our residency in conjunction actually, so our pediatric colleagues already have an existing advocacy elective, and so we're working with some other residencies in the in kind of our health system to build an elective for our residents who are interested in advocacy to engage with, I say team, but it's really one person who is sort of the UC health advocacy person, and sort of become familiar with the local and state kind of stakeholders and sort of relevant advocacy experiences, so they can start kind of learning and engaging with that. And so that'll be available to everyone, but is sort of being spearheaded by a few particularly interested residents with some experience in advocacy spaces. So.
Yeah, I would also add at VCU we have, although this is, I don't think particularly well known to the residents, unfortunately, but we have patient navigators during the day that are actually down in the ED. And the plan is to, increase our screening of people with housing insecurity and really having the patient navigators meet with them before they even get to the back of the ED, just to kind of help get things going as far as, abilities to help them and to help, not just, again, give them the free meal, but give them something that is more lasting or more resources, or see how we can help them and help to get them into their, take care of their complex medical problems as well. We've also started a multidisciplinary committee with faculty, with residents, with nursing and other staff, supported and sponsored by the health system, to truly try to work out more of this and help with education for all of us. And I think that's promising, but really early.
All right, we've got just a minute or two left. Any last comments from any of the panel? Anything that you want people to kind of take away or make sure that they impart to their trainees?
I just want to make everybody aware of this last slide here. We have a couple of QR codes. The one on the left has a summary of just the main talking points, and then a list of the lit review. And then the QR code on the right, again, is the program survey. And then of course, our contact information is on the left. So I want to make sure that we have that accessible to everybody.
And I want to thank all of the participants and the moderators for talking on this important subject and maybe raising our awareness of what's available and what we could be doing a little bit more than it was before. Thank you.
Great. Thanks, everybody. This was really great to have this discussion and have you all here.
Thanks, y'all.